Julia Raleigh and Paul Wicks. Thank you very much for being here. I'm sure you enjoyed that previous discussion. States is one thing, but IT is another one. I don't need to introduce you all because it's all up in the website, your biographies, and I just wanted to say thank you for taking the time. And so I'll leave it to Tim to start. Tim, we'll love to speak all day, so if you can keep it brief.
Yes, get the message.
I know your passion. I know. But could I also ask you to be London specific?
Yes.
Thank you.
So, at the heart of the priorities for NHS England, as the Commissioner of Health and Care Services, Health and specifically, we are focused on the development of a knowledge economy, which we believe is fundamental to the delivery of sustainable, high-quality care across health services. And what I mean by a knowledge economy is an economy that is transparent, in other words, that data safely is shared between patient and professional, that professionals are able to use data linked across the pathways of care to improve their own performance, but also to share that data in a new conversation with patients for the most part. Transparency on the one hand, participation on the other. So the deployment of routine digital technologies, routine in the rest of our lives, to empower patients and citizens to take more control of their health care and their well-being. Also. So that ranges right across the spectrum from kind of online services like NHS Choices through to very specific in-the-home applications which will just empower people to improve the quality of their lives. And interestingly, I was at an amazing event last week where we had 200 patients and citizens engaged in a conversation about this, and somebody said we have to stop talking about data and technology and instead start talking about the quality of life, because that's what fundamentally this is. An NHS that can remember people who are frequent visitors to it is an NHS that's improving quality of life just as much as it is through improvement of clinical outcomes. And then the third part, so transparency, participation, building this knowledge economy, which has been so central to the approach that's being taken by NHS England and others. The third part is collaboration, and really this is ensuring that we have a joined-up, integrated health and care system. This involves some technical-ish concepts like interoperability, not very hard for people to understand, but at the moment we have a situation which data does not flow, for the most part, between different care organisations, and indeed, scandalously, in my view, doesn't even flow well inside care organisations. So we have large hospitals, many in the capital. I think this is a real focus for London, where patients can get lost between wards, in hospital pharmacies, because things like the NHS number, identifiers don't flow with the patient. So there are some technical issues there, which we also need to resolve. So put very briefly, I would say in a London context that there's a real urgency about transparency. That's to do with both improving quality and giving accountability of local services to local communities in London, and particularly I'm thinking here of primary care and mental health services. I think there's a very, very urgent need for Londoners, many amongst whom are the most digitally literate populations and communities, even in the most disadvantaged circumstances. The mobile phone is ubiquitous amongst the poorest communities in London in a way that it's not so much in rural communities outside London. And for that reason, I believe we should be making an exemplar of London in the provision of digital services for patients and citizens to help them take more control for themselves. And thirdly, I think the challenge of interoperability, of introducing a digital integration between care contexts in London is absolutely essential. We still have a situation here where, in large part, ambulances are arriving at the scene of an accident without the patient record in the cab as they land at the scene. And there are some great examples. Coordinate My Care, I think, is about to be represented, where the advantages of integration and record sharing for primary uses is an exemplar. And just finally, this is, of course, fundamentally about improving the quality of patient outcomes, but there's another agenda as well, which I think we shouldn't in any way ignore, which is that of economic growth. I personally believe the NHS, the health and care system in general, its funding has been preserved. It has an obligation to support the economic growth of this country, and can do so through much enhanced use of data and technology. And we think of things like life sciences, the genomics opportunity. These can't be developed without our embracement of these enablers. So just some words.
Thank you. Thank you very much. Thank you, Tim. Thank you. That's wonderful. Julia, you've done a lot of good work in integrating of care at the end of life pathway. And so we thought we should have you to tell us how you did that, because it seems to be a challenge with other pathways of care.
Well, coordinate my care. We started with the patient. What does the patient want,
Yeah.
and how we can deliver the best care for the patient. And essentially, we took a patient journey and followed a patient journey and wrapped the services around the patient instead of doing it the other way around.
Yeah.
So Coordinate My Care starts with asking the patient what they want, where they want it, how they want it, and it delivers a care plan which is essentially a personalized urgent care plan. And then once the patient with their clinician has developed their care plan and it's approved, an email is generated to all the urgent care services, so the patient's own GP, the out-of-hours GP, the 111 service, and 999. And that's automatically flagged onto all the services. So when the patient or their carer call about that patient, they open up the care record and they know what to do, when to do it, and how to do it. So a simple example of last Saturday night, I'll change her name for her to keep her identity. Molly is an 84-year-old lady who is demented in a nursing home. She was consented to have a record in her best interest, and she gets recurrent urinary tract infections. Her care plan clearly stated if she gets a urinary tract infection, her GP has prescribed antibiotics. They're in the nursing station at the nursing home to give her antibiotics and paracetamol if she has a temperature, because she gets terribly distressed. So Saturday last week, and 2 a.m., she spikes the fever, she gets out of bed, she's ranting and raving up and down the nursing home. The nurse is on her own and gets frightened. She looks at her care plan, but she's not quite sure if this is actually still a urinary tract infection. So the nurse phones 111, and the clinician at the 111 service desk talks it through, because they both have the same care plan, and they decide, give her her antibiotics, phone her son as is in the care plan, give her the paracetamol and see how she does. And she did extremely well. She stayed. She didn't have to go into hospital. So she got what she wanted because of her care plan. The NHS did not have to provide an ambulance service for £500 or an admission for £2,500.
Sure. But that works only in your, if they are being through your clinic. That doesn't work if I am a 50-year-old with diabetes and get hypoglycemic attacks. Why is it doesn't work for...
It works at the moment. We rolled it out for the whole of London. This is a pan-London service, and we've trained nearly 7,000 clinicians how to create these care plans. And the first thing we did was to do it for patients with life-limiting illnesses. And now this year we're going to do it for patients, as you say, who are diabetic with potential...
You could do that too.
And we can do that for chronic care.
Thank you. Paul, do you want to add anything else before I bring the
yes,
team
I had
here?
Sort of 3 brief proposals. Number 1, let patients help. Number 2, let the data flow. And number 3, reward agile innovation. So far, a lot of people think of health in terms of something that we do to patients, and of course 99.9% of the year they are at home or with their families and things. When we raise children, we get the best advice about that from other parents. We don't ask an obstetrician or a gynecologist necessarily. They may well know everything about the processes and the biology and the systems and all that, but not about the lived experience of being a parent. And I think much the same is for patients. It's been suggested that patient engagement of these actions that people can take in living well with their disease could have the potential to be the blockbuster drug of the century. And if that's the case, who is doing the innovation on that? I would say the active ingredient in that engagement pill is other patients. And we don't think enough about the connections between people as being activating. We think in terms of health IT about what we can lock down, what we can make private, what we can protect, and rarely think about the benefits that arise from people. In terms of letting the data flow, Don Berwick spoke very passionately at the Global Health Policy Forum at the Olympics, that when his mother was diagnosed with cancer, he had a belief that I think a lot of people have, that there's this system up there in the sky, in the cloud, that when you tell your doctor, this is the life I've had leading up to this point, this is my experience of disease, that every one of those data points is going somewhere. It's going to some database where the brightest minds in our country and everywhere else, all the researchers, are looking at that and crunching it and trying to find out what the cure. And the fact is that system doesn't really exist. 90% of patients in a survey, US adult representative survey from the Institute of Medicine last week, said that they wanted their data to be shared and to be used for the benefit of other people. When we asked our members, who are you willing to let this data be shared with, as you say, in a de-identified way, 94% said share it with doctors, but interestingly, 94% said also share it with other patients. So it's not just about the medical system, it's about the other patients. Perhaps more controversially, about 80% said they'd be willing for it to be shared with the pharmaceutical industry, to learn more about their conditions, to potentially make safer treatments, that type of thing. And we looked at the differences. The UK and the US are no different. That's both at the system level, it's also at the patient level. Why are patients in hospitals right now without access to Wi-Fi in those hospitals? There are entrepreneurs out there making simultaneous translation systems that would get rid of an awful lot of our reliance on humans showing up and speaking the right language and being qualified. And then the third part is about rewarding agile innovation. These gizmos were not made by a PI in their 60s who got a grant from the MRC over the course of 5 years to do a randomized control trial. They were made by hungry, young innovators sleeping on their floor eating ramen noodles. And right now, the NHS is not a good customer for those people. There are people down there at Tech City and Silicon Roundabout, and they don't want R&D tax credits, they don't want cheap office space, they want customers. So, my challenge would be, can London be the customer that the NHS is struggling to slowly become to make all these other things happen that we need?
Thank you. You're a deregulation champion. So,
thank you for all of those presentations. For me, there is something about the what we know, certainly from our work at National Voices, that people with continuing health needs want precisely the sort of thing that Coordinate My Care delivers, which is a personalised care plan that they've been involved in, which can then actually drive behaviour across teams and across organisations. And I think that what you've been doing is fantastic. How is this going to be rolled out across? Why can't everybody who has a chronic condition benefit from the Coordinate My Care approach?
They certainly can. I think it's a complete transformation of care, and it's a culture change. And so to change the culture of professionals has required an inordinate amount of training. And this program has been sponsored by the LETB, the London Education Training Boards, which has been fantastic. And we started off slowly because 0.56% of London's population will die each year, and so they will have a life-limiting illness. 10% of London's population will have chronic diseases. And so we started off slowly with life-limiting illnesses, but now hopefully this year we'll develop it so that all patients with chronic diseases can get their own care plan. And as Tim said, by the end of the year, funding permitting, we will have everybody have their Coordinate My Care record on their mobile app. And so they'll get their app, they'll be able to look at their own care plan, and they will also be able to have their own portal to drop their own, all their own medical records into, much like at the beginning of life when we used to have the old-fashioned maternity yellow book. Well, it will now be digital. So actually, patients will be in control of their own records, and they're much better at looking after their own records than the professionals are. So there's no reason why it can't be used for chronic care, all chronic care.
But part of the challenge is training clinicians to be able to work with this system.
Very much so. There have been huge cultural differences. GPs have historically used their own IT system, and Coordinate My Care, by the end of the year, will be interoperable with their GP system. So the first time ever, GPs are sharing their records, their own patients' records, with social services, emergency care services in the hospital. This requires a whole different mindset to creating a record. In hospitals, we do it all the time because we only have one record, so we all share the same record. But there have been all sorts of cultural issues that you have to overcome in the innovation. And as we were saying, innovation is very hard because you start the innovation and then you find actually you need support for the innovations, and you need political support to overcome the political problems. You need communication and marketing support to get the message out, and in this case the message out delicately but comprehensively to the patient population. And then of course you need funding. We're still looking, can we actually put this on an app but we have to wait for funding. So there are things that wrap around innovation that speed them up. And my thoughts to the London Commission are to look for the innovations that show deliverable outcomes, and then support those and wrap around them the needs to deliver them.
Thank you.
So one of the things I notice as I go around London is, I mean, I'm a big fan of Coordinate My Care. I've been a fan for it since it started. But across London, there is a myriad of different systems, this being a very good example, but I could name a number of others, where effectively the objective is the same. It's a single care record for a defined patient group to be shared across a multidisciplinary team. Mm-hmm. What would be your view, and others might have a view on it, should we mandate more consistency across London, or should we let 1,000 flowers bloom? Because there is huge amounts of investment going into these sorts of things locally. Mm-hmm. And I certainly have sat in forums where a local solution versus Coordinate My Care has been debated, and that then links obviously with the work that... So what's the view about that? Should we just let it all run, or what?
Well, just to say, so the essence of the future is about standards-based activity, so no one's going to prescribe particular solutions for a particular local health economy. And in fact, NHS England has rightly prioritised the personalised care plan as an important kind of focal point for change, particularly in out-of-hospital care. So we largely personalised care planning is the responsibility of the primary care physician, though with some exceptions, also secondary care physicians. But the essential point at the moment is that many people are paying lip service to it, especially in London, actually. So the idea of creating a much more using this as a much more interactive tool where patients have an equality of access and even editorial rights is something which we've prioritised. Now, what we need to now do, as we've said we will do, is develop guidance which can be, on the stick side, kind of mandated through things like the GP contract and other things, but much more importantly, on the carrot side, demonstrate to clinicians this is a tool which will help them enter into a new kind of relationship with their primary care physician. So this should be standards-based. London has a fantastic opportunity to in a way incubate the future in relation to personalised care planning. I think at either end of this table you've got two of the most important partners in developing it. So Sam, I know, already does it brilliantly in East London, and Jeremy obviously has been thinking very hard about kind of the way in which patients can get most benefit from such an initiative. But just to say that it's, you know, as an example of it, Coordinate My Care is fantastic, but I think it would be wrong to as it were, mandate a particular solution rather than create a standards-based expectation that we would expect patients to be able to get access to this kind of service, however it's finally delivered.
But we wouldn't actually want you to mandate Coordinate My Care anyway, because all the mandatory fields which are mandated can be interoperable, and into Coordinate My Care they will be interoperable by the end of the year, so people can put the mandated fields into their own systems but deliver it centrally to be used.
And the other area, so one of the things we've been doing in London is publishing data on My Health London. And we've published data on GPs and so on. And one of the questions I often ask is, what is the evidence that, if we take primary care, for example, and the outcomes of different practices, has that influenced Londoners' choice of practice? You know, it's that age-old thing, people are more likely to change their bank account than they are a GP, and that's a particular issue for us in London. And indeed, if you look at the data that's up there, you can see satisfaction levels with people's GP being high in some cases, but if I looked at other markers, QOF markers, or markers relating, for example, to say blood pressure control or blood sugar control, you might find that satisfaction might be high, they have a nice relationship, but maybe some of the clinical outcomes. So,
well, I think you need contemporaneous data so that the clinicians who are delivering the service need to get their data, and they need it monthly.
Yeah.
So for example, in Coordinate My Care, the data come out. They come out monthly and they're distributed to all the 7,500 clinicians. And what we were able to show was Hillingdon had the most extraordinarily good care for nursing homes. And so other CCGs went to see what was going on in Hillingdon, and we've copied Hillingdon. And so last month, Camden have copied Hillingdon, and Camden are now the best. So actually, you can share good practice if you get the raw data coming out quickly.
I was picking up on this idea of unleashing the people of London with data for them to make, in the example, of giving better choices about general practice.
So to be clear, the evidence that transparency of that kind of outcomes data drives choice is pretty weak. I mean, it exists in a variety of systems in other countries, but we haven't really done it yet at a level of disaggregation that makes sense to people. We've published data on hospitals. People don't really choose hospitals. They may in the future, but we've just literally, partly My Health London initiating, but now Choice has started to publish data on GP practices. And my certain belief is that will start influencing behaviours. We've seen some example, and I can give details to your secretariat of these. Barnsley, for example, where some years ago they started to publish data by practice, very large numbers of people re-registered with GPs that were perceived to be better than others. There are some good anecdotal examples, but not a body of evidence. However, where there is a body of evidence is that this data drives improvement in clinical practice. So the first most important impact of transparency is on generating what I sometimes call an honourable competition between clinicians to do better. And I mean, I'm just thinking about the London example. My Health London, Howard Freeman and colleagues, someone in the room here, won the HSJ award for innovation last year because they were able to demonstrate that even in the first few months of publishing data, which is about the quality-ish of primary care, they drove down in their on a reasonably peer-reviewed basis A&E admissions by 25%, and as a result they won the innovation award. So even at this early stage of this revolution in sharing information, we are beginning to see really, I think, convincing evidence that the first impact is of improvement in clinical practice. The choice shouldn't be our main driver, but it's something I believe will come. But we need to publish the right kinds of data, I think.
Thank you. Paul, very briefly, because I'd like to see what the others want to.
Yes, so it's interesting we both mentioned terminal illnesses and life-limiting illnesses as being places where we started. We actually started off in motor neuron disease, and in that disease you get a preview of 20 years of standard ageing and degeneration in a snapshot of 18 months. So for us it's that secondary and tertiary care where there's far more variance accounted for in the outcomes of the patient in terms of quality of life, where you see more of that type of stuff. GPs, maybe you're not seeing it on quite the same level, but someone just diagnosed with Parkinson's should know pretty quickly if they should go to King Square Kings or wherever it is that they should go. And it's in those communities of like people where those discussions will flow. I'm not sure that just people that live in a particular area, for instance, if they don't share asthma or diabetes or pregnancy or whatever, are necessarily going to be approaching that primary care issue from the same perspective.
Thank you.
Three things were going through my mind. The figure that's bandied often about terminally ill patients, the percent that die in hospital is about 6 out of 10. In terms of Coordinate My Care, what do you think that could be brought down to? Because all the feedback we ever get from patients is that ideally they want to be dying at home, surrounded by their loved ones. That's the first question. The second one is my mum's 86, and she has an iPad, she has a mobile phone, and she's been in and out of the care home, Abbey Fields, and hospital, and at home. And all her kids, 7 kids, can Skype and do, and absolutely vital to her psychological well-being in everything she's going through, in the care home, at home, but not in the hospital. So what percentage of good Wi-Fi do we think we've got in GP surgeries and hospitals that will enable what is absolutely vital, actually, to the well-being and the recovery of a patient? And tagging on to that, recently in health centres in our area, and you find this across the NHS, when you compare the hardware to what you and I would have, cameras, microphones, you will see the most basic of Dell. So what do you think of the percent of computers in the NHS are actually fit for purpose? And, the final thing in sharing data. So Tower Hamlets has just been announced that they're the top in the country for blood pressure and cholesterol control in diabetes and ischemic heart disease, with early evidence of reduction in complications of diabetes and admission with heart attacks into hospital. And one of the key to that has been data sharing among all the GPs. So any GP can see by named practice how they are performing against a absolutely massive number of different statistics. And we are very clear that that has driven up standards and quality. Why isn't it happening elsewhere?
Right, very briefly, sorry, we're running out of time.
Well, I'll answer your first question. We've got just over 10,000 patients with Coordinate My Care records, of whom just over 3,000 patients have died. And of the patients that have died, 79% have died in their preferred place, and 81% have died outside of hospital. So we've only got a 19% death rate in hospital. So the data support community, patients dying where they choose.
Yeah,
Sorry,
really quickly on. So we should talk about Wi-Fi. We've released a big capital fund into the health service so that people can start deploying a variety of digital record sharing approaches, Wi-Fi being one of them. I can talk to you more about that, but that's the tech fund, or Safer Rewards, Safer Hospitals. The GPIT, Dell and the computers thing, we need to work hard on giving primary care physicians much more autonomy over how that money is spent, which we're trying to do. But again, just in brief, don't have enough time to go into now, but recognise the issue. Data sharing. So everybody, I'm sure, will be aware of the media coverage connected with a programme called Care.Data, which we've just started, which is basically making the argument that exactly what happens at Tower Hamlets should happen everywhere else. And in my view, it's a fundamental disgrace that GPs around the country are not always able to compare data in the way you describe. I use as my example here the amazing work you did on driving up immunisation rates through shared data. So you got to herd immunity in various populations very quickly, which otherwise wouldn't have happened. And our biggest challenge by a million miles is the cultural opposition or the cultural uncertainty that this kind of programme generates within general practice. So I think the public absolutely buy the idea of data sharing. I think primary care physicians are much more sceptical. I think there's a real complexity of reasons for that. But if London is going to lead the world on data sharing so that we can have an intelligent health service in London that allocates resources effectively, drives up outcomes, we're going to have to do something about the culture of the internal world in relation to recognising the benefits of such a programme. So that's
Thank you.
Andrew. Just very briefly, Tim, you said that London should become a digital exemplar.
Yeah.
Can you give me one or two tangible examples of things you think we should do or recommend that would make that the case? And Julia and Paul, having succeeded in developing fantastic products, what do you think would enable more people to develop more products like the ones you have managed to do, but much more readily and much quicker?
There's one standout one, which is just like we should be doing it. So the government, interestingly, and everyone is committed to giving every citizen that wants it online access to their records by March 2015, to their GP records by March 2015. So one of the things we've got to make sure that in London that target is absolutely met, that 100% of people who want it can access their GP record online. But I think you should go one step further, and I think you should say that by March 2015, and we'll help you in whatever way we can, you offer access to all records that people have in London, hospitals, social care. Now, we've got some good levers here. We've got things like the Better Care Fund, but I think we should be looking for giving patients access to the entire footprint of their themselves. It is their data across the health service. At the moment, we're committed to doing that in primary care. We'll move as quickly as we can across the country to broadening that offer. But I think London stands a good chance of, with real focus, doing it for across the whole care pathway.
Okay. Thank you.
So I have nothing more to
Okay.
You need to be able to make money by making people healthier. There aren't models to do that. The reason that our primary customers are the pharmaceutical industry is because they are incentivized to measure the change that one of their products make through a randomized clinical control trial, and they're paid on that basis. You can get paid to produce syringes or envelopes or whatever it is, but it's very difficult to actually get paid to say, well, look, we've published data now, we're coming out with something where we've done this with the VA. Patients talking to one another reduces people with epilepsy having seizures and going to A&E by 19% because they learn how to manage themselves better. If I had a pill that reduced seizures by 90%, I'd be a billionaire. But, the simple truth is these lower cost, digital, more scalable things aren't in the line item budgets. They're not really there. And so you get assessed in a different way. They say, can you do a randomized control trial, please, of, I suppose, interacting with patients versus, interacting with actors as the placebo group or something. We're trying to take the old models and apply them to these new technologies, and they're just not kind of fitting together.
Are you working with the NHS?
We're looking at ways to do so.
Like me?
We're looking at ways to do so.
What would you do in London if someone asked you? What would that look like?
I would ask someone to make a bet with me about the 20 most costly secondary and tertiary specialist diseases, on where we could measure those outcomes systematically and address them at scale through nothing but interaction between the patients. Things like quality of life, things like adherence, better self-management. You could use the patient activation measure, something like that. And a system where you could say, we believe X people will move by Y%. You could see the results of that in 12 to 18 months.
Well, could you send us something on that?
Yes.
Yeah.
Thank you.
Can I just add one final thing? I know I was only add one thing, but there's a second one which I think London's already got a head start on, where we could see. So one of the other most important things we can do in this generation's contribution to this public service is encouraging customers to feed back on the quality of service they receive. It's a fundamental stream of data that we know drives improvement that we've been very poor on developing. And London has already developed a pilot program called Care Connect. There's lots of work going around patient-centred outcome measurement. I think a very concerted approach to ensuring that patients in every care context, citizens at large in London, have a very easy, accessible means of giving their feedback on local services will generate some fantastic intelligence around how services can improve. And I'd just point you, as a committee, to the example of what happened with 311 in the US, which did revolutionise not just the economics of American city management, but also the legitimacy of the way in which they made their decisions.
Thank you. Could I thank you all for being so frank and great ideas, and please send us more stuff if you can, and a lot to learn from you. Thank you very much again. Thank you, Tim.
Cheers.
So